Afternoon. It is 1 o'clock Pacific, 4 o'clock Eastern on a Thursday. It means it's time for THCB Gang, where I'm Matthew Holt, the sort of founder publisher of THCB, brought to be on the Twitters, put together a group of itinerant layabouts and people who know about healthcare, usually with I'm a bit of having a rather weird Zoom moment for those of you watching on the video. So we'll turn off the video for a second, turn it back on. Hi, we're putting together a bunch of itinerant layabouts who know about healthcare, and in this case, and sometimes speak, with a funny foreign accent, depending where you live. But one or two of us speaking the Queen's English. So, who do we have today? Kim Bellard, regular writer and contributor to THCB. Casey Quinlan from the Healthcare is Hilarious podcast. Jen Goldsack, who runs the Digital Medical Society in her spare time while she had a day job, and Ian Morrison, health futurist. And it's great to see all of you. And we're going to start with some fun and games about medical care, because far too many of us have had far too much recently. So I'll start.
And not because we wanted it.
Well, I was warning the people about my back injury. I had both a back injury, which seems to be getting better after a steroid injection right at the end of last year, and I sort of got it in under the deductible. And now I'm just arguing with Chemok and CBS about my kids' drugs. Although I did have a bit of a scare where I thought I had a detached retina last week and had a bit of yellow pages medicine trying to get to an eye doctor. And if I saw one and he said, "Come back in 2 weeks, your retina is not detaching, that weird flashing and all the floaters you're seeing, that's all something the Mayo Clinic worries you about, but it actually isn't a problem for you." So that's me. Now, next up, we have somebody who has had a lot of surgery recently, a lot of fun with the healthcare system. Ian, how are you doing?
I'm great. I'm 7 weeks post-op from quadruple bypass. So,
and I was going to say that the reason you haven't on THCB Gang lately is because you were resting up, but actually you've been working.
Well, yeah, a little bit. I'd sort of conflicts a couple of the Thursdays, but it's nice to see everybody. Nice to be anywhere, actually, after you go through all of that. But
how are you doing? Pain wise and getting?
Oh no, I didn't have any pain whatsoever. I mean, I think I had 2 oxy. I don't know how anyone gets addicted to oxy. It made me feel very squirrely. But no, I got, well, yeah, they kept saying there's got to be something weird about pain tolerance. But if you played rugby, it probably is an explanation for it. But anyway, I'm doing well. I'm going to cardiac rehab 3 times a week, which is basically gym class for old people, which is fun. But no, I'm walking and moving around. I can't play golf yet because you've got bolts in your wires in your chest and stuff like that.
Yeah.
But anyway, I'm good, on the mend. A miracle. I'll tell you though, and this may be the punchline for all of us who've gone through this. I mean, the juxtaposition of that with the Commonwealth Fund stuff this week. We may fail at a population level, but it's still remarkable what American medicine can deliver, and we shouldn't forget that.
Absolutely. Talking about Brits using American medicine, Jen, what have you been up to? You said you were in bed because you just got a knee surgery. I didn't know.
Yeah, so I mean, and Ian, to your point, I mean, how lucky are we who are sort of fortunate enough to be able to access this? So Matthew, as you've revealed a few times, I had a less than salubrious career before getting into healthcare. I was a professional athlete for years, and I was very lucky. I had this sort of monster physiology, pain tolerance, sort of lactate thresholds, lung capacity, terrible connective tissue, terrible joints, but I never really let that stop me, but I'm paying the price now. So actually ended up, and I'm in Florida, and this is enormous instance of privilege. Just got back yesterday because I have a long-standing relationship with this particular surgeon in New York, Hospital for Special Surgeries, absolutely the preeminent person at the sort of care that I've needed. Was able to fly up last Monday, went in, I mean, I would say had to do all of my pre-op testing in New York in the hospital, which for a very, very healthy 40-year-old, I think was ridiculously overly extensive. Also had to do it in hospital because the wait for a primary care provider in Florida is 2 years right now. Was able to access, fantastic treatment, inpatient for 1 day. But my husband was able to fly up with me, and we could afford to fly up, and we had this tremendous surgery, tremendous surgeon, had the option to stay in inpatient. my husband had to come back to work. My great friend was able to come and stay with me in a Marriott for 8 days before they cleared me to return home yesterday. All of these things are sort of markers of privilege that allowed me to basically save a knee joint and not have to get a knee replacement, but available almost exclusively to me. And it makes you think, right? It makes you think about what's available at the tip of the spear and the way we actually think about caring for everybody. Back to your point again, Ian, about the recent Commonwealth Fund report.
Yeah,
That's fantastic. Well, Jen, but your knee's good. Yeah, that's so far. I mean, you started your rehab.
I mean, they smashed it. It's fantastic. And I'm ahead of my rehab goals, as I like to be. So it's all going well.
and Jen smashed it
right here next to the
Smashed it in the
smashed it in a good way, right?
Smashed it in a good way, because that's more Brit
Right.
slang.
Yeah.
I got it,
I
because
think they
you
actually
know, I
smashed it
lived
in a
over
bad
there
way
for a good
first,
while.
as I'm black and blue from like the thigh to my
Oh,
foot.
they
Oh
literally
yeah, no, totally. It looks like they smashed it, but they
Okay.
didn't.
Exactly.
All right, Casey. While we're on the people who've been hanging out with the healthcare system quite a bit.
Well, yeah, you know, a little stage 4 cancer recurrence, you know. It's just, you know, like, okay, we'll do this now too. But I mean, actually it was orthopedics that finally led me to figuring out what was going on with the vicious pain I had in my back, which I've had on and off for a long time, starting in my 30s, because, you know, for a good while as an engineer in network television, but from the female gender, I had to prove all the time that I was tougher, stronger, could work later, could, you know, drag that further, you know, et cetera, because there was only a few of us at the time. Now that's changed, blessedly, but I definitely did myself, you know, permanent injuries doing, you know, all kinds of stupid things around grabbing equipment and dragging stuff all over everywhere. And, but anyway, so, you know, years later now at 70, I get to have the cancer recurrence thing. I did have a very good visit with my oncologist today, and I start a new medication on Monday, which, looking at the side effects, because the last medication that was oral that I was on tried to kill me. And I kept landing in the hospital, or as I call it, the slammer. I kept ending up in the slammer, and I was not happy about this. And, you know, I mean, they had taken me off the drug, but trying to get my blood levels in various areas back into something and get my kidneys back online, because that's what kept on trying to shut down. Trying to get all that going turned into a real project for some number of months. And so they put me back on classic chemo, ergo the new look. But I'm just going to keep it this way for now, because who knows if they're going to need to do something like that again. And rather than, you know, get tied up around, you know, like, do I have hair or not? I kind of don't care. You know, it's like, am I alive or not? We're going to go with that metric. And as I tell people, I get up every day and I act like I'm still alive. And so far, that seems to be working.
So, Kim, you better have something really bad that happened to you. You must feel really left out. So.
Well, I did have a heart attack 6 years ago, so I'm a little bit in the club, but I'm trying to, you know, stay away from trouble.
Forgotten
like
about that by now.
Yeah, so I'm relatively healthy. I do go in a couple of weeks to have some laser treatment on my gums that my periodontist thinks is a good idea, so I'm not looking forward to that.
Who knows? Well,
Yeah.
Well, look, it's good. It's good. We're all still here.
We're done with the organ recital now. Let's move on.
We're done with that part. We should probably. And I've been having a bit of fun and games trying to figure out. So I don't know how much of you go through the whole spiel when you do this. So like looking at all the OBs, trying to figure out who got paid what, how much it would have been if you'd done this. I know. Casey, now you're now in the Stalinist Medicare program, which has one price and doesn't.
Oh yeah, no, I'm on original Medicare
Yeah.
with a supplement, which the supplement that I got is terrific, but it's no longer available apparently. I mean, for new people.
No.
So you know, we'll see. So far, so good. But I will say that Medicare Advantage is not really an advantage. So I would caution people to read Meryl Guzner, Wendell Potter. You know, there's a lot of people that you can follow for information about why that's the case.
Let's start on that one, because there's some interesting stuff here, right? So George Halverson wrote a piece again recently on, and there's been a lot this week. So let's start there. And I know Ian's been involved in this as well, but the whole issue of Medicare Advantage. So we talked about a lot, but the bottom line, it seems to me, is that there is a good deal of evidence that historically there has been a lot of upcoding in the risk adjustment factor by the plans who, as we know, get paid. For those of you who just joined us and haven't heard about Medicare Advantage,
If you've been on another planet,
right? Well, maybe the plans get paid an amount per head, and it's adjusted based on how sick the people they're managing are. Now, there's been a lot of discussion about this for many years, and many of us have been very cynical about it. This week, it looks like the plans are now going to have to be audited for anything they got since 2018. But if you go, the data that CMS is now coming out with suggests that they are having to go back all the way. I have to click on and off for this damn video thing to make me look more beautiful. That the data they are dealing with suggested that this upcoding's been going on for a long time before that, but they're not going to be billed sort of going back to 2011, 2012. Having said all that, it does still seem to be the case, and what George Halverson would say if he was here, and pieces he's written, is a couple of things. One is that although MedPAC, which is a bunch of outside experts, seems to believe that Medicare Advantage costs the entire system more than traditional fee-for-service Medicare, there are actually, the CMS trustees have put out a bunch of data which has been seized upon by the various groups like AHIP and the CHAP, who are defending the plans, to show that actually some of the costs are rather less. Now you can go to George Halverson's stuff and say that actually no, they're charging less. George's point is also that they're no longer able to do risk adjustment by sending nurses into the home and do all the things that Signify, which just got bought by CVS, right? CVS Aetna, we're doing to upcode them, and instead they're now just having to sample out of actual medical records, which shouldn't be lying there for about the actual sort of how sick the people are, how sick the individual members are. So it still seems to me that both these things can be true, right? That you could actually be delivering cheaper care than fee-for-service Medicare, and still be upcoding to get much closer to the line and getting more money in. Because for years and years and years, fee-for-service Medicare is, although it pays a low price, has a myriad of inefficiencies in it. The one other thing I'd say that George says, which may be true, and this kind of goes back and forth, Casey, to your point, is are the quality measures being delivered by Medicare Advantage better or worse? And George would say yes, they are. And he has a whole thing about foot amputations under Medicare Advantage being 1/10 of what they are in Medicare fee-for-service. Don Berwick wrote a piece saying that that's not true. So going backwards and forwards, there's still a lot to debate here. But anyway, Kim, why don't you you've been looking at this for a long time, why don't you give me your quick overview of it?
There's overbilling in the healthcare system. I'm shocked. I'd like you to point to me some piece of the healthcare system that does not try to maximize their revenue from their patients. Hospitals and physicians have been hiring people left and right for decades to do this, and health plans, once they get into Medicare Advantage and we're reimbursed on that, are doing the same thing. So I believe that Medicare Advantage plans do it just like everybody else. If you sampled anybody, they're going to find the same thing. So it's a problem inherent when you pay people more for having sicker people, and we haven't gotten around ways that we can really figure out, what is the right payment and who are the sicker people. And until we do that, we're going to have problems like this. That being said, as I've been tracking it, which is not as intense as some of you, the fines that they are imposing on the Medicare Advantage are like a rounding error for the Medicare Advantage plans, right? Like $1 billion over 10 years. Like, I'm sorry, they'll take that. They'll take that every day of the week.
Well, they're complaining, but the thing they've done is they said that they did a bunch of audits going back to 2011, 2012, whatever, on a relatively small number of patients, and then they were going to extrapolate that to everything, which would have made the fine really big going back 10 years. And instead, they're just going to charge them for those individual patients, which is a few thousand across a bunch of plans, which is not going to be much. I think it's going to be. I mean, there are two questions. Right? One is how much they're going to find him for the 2018 period to 2022, and the question is that is George Albertson right? Have they really stopped upcoding now because of the way they're tracking it? There's a couple of comments on his piece on THCB suggesting from some people who know suggesting they're not doing it. But I don't know. Ian, you're now a proponent of fee-for-service Medicare, right?
Oh, well, look, I mean, what's the old line about consistency is the hobgoblin of small minds? You talk to everybody from Alan Ent over to Bob Margolis and ask them, what are they in? And they'll tell you they're not in Medicare Advantage. They're in Medicare fee-for-service with a big-ass supplement, right? Because that's the smart thing to do. Because if you don't do that, then you cannot go back, as Casey was alluding to, you cannot go back and buy a fee-for-service supplement without it being medically underwritten. So I have a friend who inadvertently signed up for the Sutter PAMF, Medicare Advantage plan, and he's a 20-year multiple myeloma survivor. So I mean, he could have gotten in the whammy if they didn't let him go to UCSF to the care system he was getting care from. So anyway, long-winded way of saying I'm a huge. I mean, I haven't seen a bill. I just got a thing from Stanford, where I filled out all my CAP scores, so gave them all excellent marks. But I've yet to see a bill from the previous surgery, which is kind of nice compared to.
I'm glad you said that, Ian, because I was afraid to say it because the Chi-Coms are listening.
Yeah.
But I haven't gotten a bill either. And this has been now like pushing 2.5 years that I've been dealing with this. And I have not seen Bill 1.
Well, it's because I think the reason it's not that we're going to get an ugly surprise, Casey. It's that most providers take Medicare assignment, and that they are accepting it as full payment. Now, I mean, I'm a good pal of David Entwistle, who runs Stanford. He's losing his ass on my case, because I went over the length of stay and blah, 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 on a DRG basis. I was a horrible financial deal, but the advertising effect for those who are commercially insured is probably makes up for it. I don't know.
Mm-hmm.
The only thing that's cost me so far, I gave my surgeon a bottle of our bag, which he liked.
Well, hopefully you get to him after he did the surgery, not before.
No.
That's a nice gift.
I got an email from him. I think it nearly killed him.
Yet Medicare Advantage is up to what, 40% of Medicare? I mean,
it's more than it's over half now. I think when the open enrollment numbers are out finally, it will be like 52%.
The dollars are inescapable for most people. They look at the premium. If you're not particularly sick, you look at the premiums, and it's it's a huge difference.
Yeah, no, that's exactly right, Kim. And but it is skewed by income. I mean, it's lower income because it's free, right? Like what's not to like about free? I got in this screaming fight with a guy at Goldman Sachs years ago. He was talking about consumer-based marketplace, and he was using Medicare Advantage as an example. I'm going like, wait a second, pal. Nobody's writing a check here. It's free. Free is good. If that's consumerism, then I'm all for it.
Well, I mean that's the case, right? So I mean, and so now I want to flip around here. You're racing about Stanford losing its rear end on fee-for-service for Medicare. You just went, so you went, the piece you just wrote up, it's on THCB yesterday, is about McAllen, not the whiskey, not the nice whiskey, but the border town in Texas that Atul Gawande made famous.
Yeah.
And perhaps you could just quickly go over your visit there and then say a little bit about what the people you were talking to there were saying about making money on Medicare and Medicaid. And
right. Well, I mean, I wrote a very long-winded shaggy dog story, and our good friend Jeff Goldsmith sort of taught me out of some of that. But
that's the one I wanted to publish with you.
I know.
The MAGA guy.
It's actually pretty funny. The long version is pretty funny. But anyway, the short version was these guys invited me down. I had actually been on the stage with Atul when he gave the thing at the American Hospital Association originally. Anyway, so I was sort of intrigued, and I went down, and they were very gracious. But I mean, I spent 2 days there and sort of hung out with all of them. and ask questions. And the bottom line is this, I think it revealed, kind of the inconsistencies in American medical care. I'm on the board of the Martin Luther King Hospital, as you know, in LA. And, liberal California is incredibly generous in its ability to allow people into the Medi-Cal program. Texas, on the other hand, is easier to get into Princeton than it is to get a Medicaid card in Texas. But what I found out from my pals there is that they can actually draw down on state uncompensated care funds, so they can kind of make the math work. They'll get some money, and they claim they actually can make money on Medicaid. I hear that from my clients in Oklahoma as well. So you can't get in, but once you get sick, you can get the stuff. And so, I took them at face value. I toured their hospital. It's very fancy. And, 20 years ago, there was no subspecialty care in that community, and now there is. And they're running it as a doctor-owned, everybody's a shareholder, for-profit enterprise. And I think they were reasonably well run, and they seem sincere in trying to bring stuff to their community. Now, I'd love them to be at risk for a population. That would be terrific. And they are getting nibbled away by the presence of people like Cano in the marketplace. They're talking about Medicare Advantage. McAllen has 67% Medicare Advantage penetration, which is probably the highest in the country.
So if they're at that level of Medicare Advantage, I mean, again, that's probably presumably Humana and United and whomever else, managing that. They're not getting risk payments for that or any kind of capitation. They're just a fee for service down the
Correct.
What's your sense of how they were quote unquote managing patients? And I go back to like all the stuff you hear about. So just yesterday, Accolade, the company that has bought a bunch of online telehealth companies. It bought Plush Care and it bought Second Opinion MD, but was started out as like an advisor advocate company, and it's now becoming more of a general primary care company, just to deal with Blue Shield of California, right? Where they're now announcing they're going to do virtual care and manage the system, and I kind of was Shantanu Nandu, who's been on this program a couple of times, said how great this was, and I tweeted back at him. I said a bit cruelly, congratulations on reinventing Kaiser Permanente. But basically, what they're talking about is what you just mentioned, right? Is that if you have primary care, can you make it so that the primary care is at risk and can manage what goes on afterwards? And I contrast this with my friends at One Medical, who, when my eye was going crazy, I called up there. I got straight onto their their video line. I spoke to a nurse practitioner and I said, here's what's going on. And she said, yes, that does sound like you might have a detached retina. You should go and see your ophthalmologist. And I went, well, I haven't got an ophthalmologist because I have pretty good eyesight other than my $3 Chinese reading glasses. And she went, well, I said, can you get one for me? You're my primary care doc. Can you help? And the answer was back to the yellow pages, right? She looked up somebody and I looked up somebody and we dialed around. And eventually I found somebody who could see me that morning, which apparently if you have a detached retina is quite important. But it wasn't like they have a system, even though
right.
They have a system to plug you into the way that presumably the Kaisers of the world can. Do you get the sense that can be in a place like McAllen where you've got Medicare Advantage, but basically this pro-capitalist fee-for-service hospital system? Do you think that's happening? How do you think that's?
My takeaway for them was you got to fix this primary care problem, otherwise the Canos of the world are going to cut off the deal flow. Right. So you do have to sort that out. But the corollary is also true. And I wrote about that, when you had your first Techies VCs conference, Matthew. I mean, I think with all due respect to the digital health world, there is this kind of, I think, naive notion that by doing digital primary care correctly, you eliminate the morbidity and mortality in American life. And that it's just not true. I mean, look at Kaiser, been doing it for 75 years and they still have doctors, hospitals, surgeons coming out their ears, right? And I think it goes back to this thing. If you look at particularly poor populations hard enough, everybody's got something wrong with them, that's operable. And if you can find a way to do that, which is what these guys are doing. Now, whether that's the right way to run a store, I mean, what the article also says is Daschle got it right back in the day, saying you got to build a platform of primary care. And that's why the Brits and the French and the Germans and the Dutch and everyone else looks better, because they've invested at the bottom end of the pyramid, not at the top. But I owe my eyes, I guess, to there's more than one way to skin a cat, and is that community better off with them or without them? And I would say they're better off with them.
Yeah, and that's probably right. I mean, and David Kimmy's piece, which was, I reprinted from 2009,
which is great, by the way. I mean,
great piece, how basically, the for-profit hospitals came in and built the environment that Atul Gawande was sort of complaining about. Was pretty interesting, but I think you could sort of flip it around. Jen, I just want to drag you in here because Ian was
criticizing. Yeah, I wanted to point at Jen and
we're all pointing at
question.
There's something to do with virtual first primary care. You may know something about. So
exactly,
this is where you leap to the poor, beleaguered digital health community's defense.
Hey, they're not that poor and beleaguered. They're doing pretty okay and doing some good work, I think. I mean, I think we need to be really careful about what we even mean by good virtual primary care, right? Are we looking to absolutely displace brick and mortar facilities or a personal relationship? Absolutely not. But I think there are two things here that we've actually spoken about on this call that are pertinent to this conversation. The first, I had to go and get a series of pre-op testing in a sort of level 1 hospital in Manhattan because I talk about the yellow pages. I went through just about every primary care provider in a 3-county region in Florida. And the soonest someone can get me onto a list is 2 years, right? So we need other options. It's 2 years. The other one, I think, and this goes back, Matthew, to your point about needing to see the ophthalmologist. I think that virtual care, primary care in particular, but virtual care done well, the difference is that it should be providing solutions and not recommendations. And I think that this is it's a punchy line, but it's not, hey, we're going to refer you to this, here's your prescription, you go and figure out how to fill it, right? And I've got a slew of medical devices I'm trying to get my hands on right now just for, rehab. It's also not, you need to now go and see this specialty care person. As you're checking out at the desk, there's 1,000 business cards and pamphlets there. Good luck to you. It's actually connecting you with those solutions. And so I think we actually have to redefine what we mean by good virtual care. And the very best virtual care that we see is using data-driven solutions, is really thinking thoughtfully and carefully about what care transitions look like. And they aren't just providing opinions and recommendations, which is what most doctors do unless they're an interventionist. They're actually giving you a solution.
Right. No, that's well said, Jen. Can I just ask, because you guys track this more than I do, whatever happened to Glenn Tolman's Transcarent? I mean, because that's what he was supposed to be doing, I thought. I mean, and how many lives? I haven't seen any.
So there's some interesting stuff going on here, right? Among other things, there was an interesting article this week or last week about, it wasn't actually about Glenn, it was about Zane Burke, is the guy he brought in to be CEO of Livongo, about, what kind of a deal was it that Livongo sold to Teladoc, and, there's some back and forth about that. But the Transcarent thing, I mean, Glenn was on that conference that I ran with Jess DeMassa
right.
last year, but 2 years ago now, a year and a half ago now, about, and he was saying, well, we're not an advocate organization, we're not a navigator, we're not like Accolade, or we're not like Included Health. But it seems to me, that bucket of companies, right, which includes Accolade, includes Included Health, and does include Transcarent, all very well funded and have got either actual primary care docs, virtual primary care docs now on board, and mental health, close relationships with mental health, or doing their own mental health stuff on board, looking more and more kind of like what Teladoc would be like if it was a virtual, it was a primary care rather than urgent care telehealth organization. So there's that, and they have put, what Glenn's done is he's attached Transcarent to, some large hospital systems. He's kind of made a choice about who you go with. So I think they did a deal with Cleveland Clinic, and I think they did a deal with somebody else in Chicago, and they already bought a Center of Excellence company. His name I can't remember, but it's one of the ones that's kind of competing with the folks who did the deal for Walmart. So they've got enough of the pieces in place where theoretically, they can get you to the telehealth immediately and should be managing you through the system. And on the other hand, if you look at how well those individual companies have done, I don't know about the virtual care first plans put together by the health plans, but if you just look at those three companies, I think included has got the most lives, and it's less than 10 million lives, right? So it's, even though they've got some big employers, it's not that many people. And I was kind of complaining about I think it was my retina or maybe my back, that that this kind of level of moving you around inside the system and doing what Jen says, giving you a solution, not just to a random recommendation, you're on your own, pal, kind of stuff, it is not available to very many people. And I'm probably, outside Kaiser and, the few people who included health is working for, almost no one's got it.
I think you might be surprised, actually. And I'll give you an example. So at Dime, we run the Impact Initiative, which is our virtual first care initiative. And actually, we just launched a virtual first care directory. And so there's over 150 virtual first care providers that have gone in and outlined all of the services that they provide. And we talk to all of these organizations as well as the payers. So we have CVS Health and Aetna at the table. We're chatting with UHC, we're chatting with Elevance. We talk about what their vision is, but the ethos of these virtual first care providers, certainly within our community, is to provide solutions, and they are drilling towards that, right? So if we look at a specialty GI practice, right, they're a virtual first care provider, but first of all, their GI docs are delighted, which is, I think, a victory in and of itself. But when they do need to refer someone for an endoscopy or for a colonoscopy, they manage that entire process and they make it seamless for them. And they make that a core part of their business to make sure that that patient is getting the care that they need. And so, have we done it holistically with all of the pieces yet? No, but it's a complex industry. And I think that is what the tip of the spear leaders in the field are driving towards. And I think it should be the standard that we hold them to.
Yeah.
Years ago, when narrow networks were becoming the vogue, I wrote a couple pieces saying that the insurers are missing the boat here. They're becoming even more the people that are keeping you from going to the providers you want to go to get the care you need. And when instead, what they should have focused on, and what they should be focusing on now, is becoming your concierge, getting you to the right provider at the right price with the most effective care. And so what's happening instead is all these other intermediate people are starting to form up to do the things that the insurers should be doing, but instead are not. And so the insurers are hated because they're keeping you from what you want to get. They should be helping you get the best care, and that's going to turn out to be the most cost-effective care if they do it right.
And the irony there, Kim, and you're exactly right, is that what's required to do that well is data. And insurance companies have been doing the backstroke in data for a very long time and have chosen not to use it. But as we increasingly have access to these flows of data and that we can perform the necessary analytics, this is the best navigation companies we're seeing coming in provide clinical care, navigation, and they use a data-driven approach to do it. And I think that's the trifecta. And Ian, back to your point, I think this still doesn't say that we want to do away with the brick and mortar primary care provider, but I think we have to embrace the new approaches that the newcomers are sort of setting the standard with.
Yeah, and just to build on that, I mean, I just got off the phone an hour ago with Ken Kaufman, the Kaufman Hall, for a thing we're doing together. But, he was pointing to me to the bottleneck that hospital and health systems are leaving all kinds of revenue on the table because they're incapable of getting specialty appointments and throughput. So, I mean, theoretically, the approach Jen's talking about, where he cited GI, his wife having to wait like 3 months for a rescheduled colonoscopy. If you do a front end that can actually, what was your line? I loved it. Deliver solutions, not recommendations, that you get to the point of saying, yeah, you have, the need for a more serious surgery. And right now, the Palo Alto clinics and the Stanfords of the world are incapable of doing that, at volume. If somebody else can do it, they're going to make more money on the back end of the complex stuff. So there is a potential win-win here, and it may be the source of partnership. But I worry a little bit about Matthew's experience. I mean, I love One Medical. Don't get me wrong. I think Tom Lee was a genius, and Mir Rubin's a friend. But the problem is it was discharged to the ether, right? After the primary care stuff. I mean, my son is a member, and he had this dermatological condition. They were like, so where's your dermatologist? Well, we don't have any, you know. here's the phone book. What's a phone book? You know.
Well, there were two heartbreaking stories just in the last couple of days. One was ProPublica, I think today, about a Penn State University student whose parents fought with United in that case to get the drugs that he needed for his whatever his condition was, you know, $2 million a year kind of drugs. Yeah. And just medical review, medical necessity, blah, 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 can't do it, blah, blah. And another one was the Washington Post, their health reporter's son needed this expensive drug. So in both cases, you know, these are extraordinarily expensive drugs that are a problem for society. And on the other hand, the insurer then tries to, you know, not have to pay for that by trying to order step therapy and all these other hurdles. And so, you know, the patients are stuck in the middle. You know, the patients or their doctor know exactly what they need. They just can't get it because it's unaffordable and nobody wants to pay for it.
Right.
There's also,
and Kim, I have to pile on there for a second because you're exactly right. And I read both of those articles and they are absolutely sort of gut wrenching. But here's the other thing. 1 in 4 Americans with diabetes ration their insulin because they can't pay for it. Right. This is not just the high end specialty $2 million a year sort of drugs that you need to save your life. For a start, insulin has been used in humans for 101 years. I know that for a fact. Mm-hmm. It's not innovative, right? And we still haven't figured out how to commoditize it and to make it affordable and get on the $5 plan. 1 in 4 are rationing it.
And insulin,
and this is something that was patented, and the patents were sold for $3 to a couple of pharma companies that still hold the core patents on it and are just, you know, they keep playing the, you know, new molecule game. And, you know, when I disappeared for a minute, it was me going to talk to, you know, somebody who was calling me about my new drug that I started on Monday and my access to it. So I've been approved. I get approved. So I get my med, but luckily I have a couple from last year I have a couple of cycles, so I'm not caught short. But still, it's just, this is a dance that everybody that's, you know, got any kind of medication need is, you know, doing all the time.
Right.
I have to do it every month for my pain meds, you know.
Insulin is probably the best example of the fallacy of cost sharing. Like, what you're telling diabetics that they're overusing insulin? Is that what the message is? No, I mean it's a penalty on sick people.
Yeah,
it's exactly what it is.
So there's a couple of interesting things here. One is that there's a similar lesson I've seen come up recently on Twitter about Humira, right, which is the best selling drug by value in America, $20 billion a year. There are only 300,000 people on Humira. There aren't many other markets where you can find 300,000 consumers and may have a $20 billion product, right? So and we know that since when it was supposed to come off patent in 2016, 2017, 2018, you know, we know all the games AbbVie's been playing to pay off other companies. Now that Amgen has got a biosimilar, there's some discussion that may only be sold for 90 or 95% of the price, and there's a bunch of games going there. And I was trying to get into this particular conundrum because, as I say in the piece I wrote, you know, I live in Marin County, therefore my kids have got ADHD, and and so they need their Adderall or the version of Adderall, and there's a couple of things going on. One is there's a big shortage of that, which may or may not be connected to what was going on with Cerebral and Ahead and Trupel and stuff doing this, or may be connected to the DEA deciding it doesn't want to increase the quota, even though since the pandemic a lot more people have been diagnosed with ADHD, rightly or wrongly. But also, you know, again, same thing happened to me. I spent a half hour on the phone with Caremark, which is the PBM belonging to that works with Blue Cross Massachusetts. And what was going on there was they were trying to figure out why my cost for the drug had gone up from like $29 a month to $105, which is the cost that is allowed by the health plan or the PBM before I hit the deductible, you know, which I have to pay until the day we hit the deductible, which is, you know, several $1,000s away. And I couldn't figure it out. They couldn't figure it out. Eventually, I could tell that the person that came up was on a Slack channel or something similar with a bunch of other people. She said, I'm talking to and messaging with other people. And it came down that apparently the drug goes from, it had been moved from tier 1 to tier 2, which is why the price had gone up, but was going to be moved back to tier 2 as soon as I hit the deductible. So I got to pay the pharmacy more, but the health plan got to pay them less. So just dealing with the complexity of this stuff and trying to figure out how PBMs work with pharmacies and where that, is nuts. And Elliot Cohen, the guy who started PillPack, responded in a long tweet stream to me about this, suggesting some of the things that may be going on. But it's still, unclear. And that seems to be the same sort of related problem as to, what are the things that the PBMs / the plans can do to get people either to not take the drug or stop it or change or go to a cheaper one or something. But it's again not clear. There's no path for me saying, there's nobody saying, hey, this drug is way more expensive, it's generic than an equivalent drug, and we can move you to a different drug for your kids or try something different, which is kind of what they're doing with the very expensive drugs. But it seems to me that again, nobody's really thought this through from the point of view of the patient, and no one's really had to go. I know there's been legislation last year. No one's really had to go at stopping the pharma companies doing what is just straight price gouging, because they made their money back on Humira by now.
I'm surprised we made it this far in the show without talking about Don Berwick's new piece in JAMA.
I kind of mentioned it, but you should go on.
Yeah,
I mean, it's hail profits is the motto of our healthcare system. He was spot on all the problems, but I was really disappointed with his, at his endings. Basically, healthcare professionals, you should be doing a better job about this. Like, well, I think that's sort of how we got into this.
Well, there's been a lot of fundamental questions this week about what our industry actually exists to do, right? So we can talk about, is it ostensibly to care for people? Is it to make money? Those things actually don't have to be at odds, but they seem to be far too often. We can look at the activity, the FTC activity around the sort of health data breach sort of notification, and what does it mean to actually respect people's privacy and to have, be good stewards of that information. And then, the other place I was hoping we could go today was, I don't know who's watched it, but the video of what happened to Tyre Nichols, right? It wasn't just the police this time. Those EMTs turned up and did nothing, right? Those are people with a duty of care. They're part of our healthcare institution, and they turned up and they did nothing, and that poor young man died. And, I think we all have to watch that video if we want to be allies. But it's really left me asking this question of, ostensibly the healthcare industry should exist to care for people, and we see all of these sort of challenges to that ethos. And what does our healthcare system actually exist to do? And those of us in it, whether you're a developer, whether you're an EMT, whether you're an insurance company, whether you're a clinical care provider, like, what are we doing here?
Yeah. Well, I think it's a very important.
That's a legit question.
Yeah, the backstop has to be, in my view, professional ethics. The problem we run into is when you've got for-profit shareholders, and who's your primary duty to as an investor. I think that gets into some of the conflict. But I was, as you were talking, I used to teach a class for directors at Eli Lilly, when they were becoming global directors, sort of up a level from manager, and on sort of global healthcare economics. And I said, basically, America is a 3% business. Everybody takes 3% profit off the top, except drug companies who take 30%. And so, don't get into the hospital business, don't get into the insurance business, just keep doing what you're doing. I think those guys need, when we were, Matthew and I first worked together at the Institute, specialty pharma was just a glimmer in somebody's eye. It's now 50% plus of all the pharmacy spend. And we have done nothing in this country, even with the laws that were passed recently, to, limit the launch price of these things. Which is part of the problem. But the insulin thing is criminal. The insulin thing is just absolutely criminal.
It totally is.
150-year-old or whatever it is drug, is
101,
unaffordable.
as Jen said.
But I mean, you know, I saw Eric Bricker does those great Q&As on his whiteboard on LinkedIn and YouTube. You know, and he had to go at Humira, and he made a great point. I mean, most of what I knew, he said I knew about Humira with the patents and the pricing, this, that, and the other. But he also said, think about it. It's right. Now that biologics and you know, especially pharma is now a big driver, there is no reason why every other biotech company producing that drug won't do the same playbook.
Right.
Why would you not want to just go after, you know, aggressively pay off people to not come with a generic, aggressively go after the patent, extend the patents for the stuff, aggressively extend the pricing, because no one has been stopping you, right? And I know that some drugs are going to come under Medicare and be negotiated, but nobody, you know, has figured out two things in America on pricing. One is no one's figured out how to stop and this is one of the things that One Medical has succeeded in doing. No one's figured out how to stop the Tony AMCs, you know, from charging way more money, and the insurance companies are paying it. In fact, multiple books have been written about that than other people. And no one's been able to figure out how to stop, you know, drug companies consistently increasing the price on drugs, you know, that have already been made. You know, the R&D's already been paid for and have already been profitable for years. Now, all kinds of arguments about, yes, well, you know, the Europeans and the Mexicans, everyone's getting a free lunch, a free ride because Americans are paying more, and all kinds of arguments about how that, you know, resolves in more R&D for drug companies. And yes, Ian, there is the, you know, the Wall Street, you know, wants more money out of whatever they can and drives activity. And that has flopped over into the not-for-profit sector in a huge way. And, you know, you look at Ascension, you look at a company, you look at HCA, you look at Ascension, you can't really tell the difference. Other than HCA gave the money back to its shareholders, and Ascension's got it sitting in its reserves. But, you know, once you get past all of that, there doesn't seem any political will to really, you know, to go after that in a big way. I mean, the effort involved in getting drug price, you know, negotiations from Medicare last year, I mean, that took what, better part of 30, well, more than 30 years, but at least 20 years since the Medicare Modernization Act was passed.
And drug companies' stock prices didn't go down after that, so they're not too worried about it.
It's going to be so trivial.
Well, and you know, PBGH for one, we're trying to get this to apply to employer-sponsored coverage too, but it's exempt, you know, and I mean, it gets what I've got to be careful what I say here, but you know, I have done in my career as recently as a year ago talks for a drug company, you know, their market access groups. And what that is code for is 300 to 400 highly compensated, leggy, good-looking people who spend their time schmoozing health plans and others to make sure that they're on formulary and make the problem of consumer cost sharing go away for everybody earning less than 150 grand. There is no drug that gets launched these days without couponing for people, you know, with less than six-figure incomes. And what they're trying to do is to get you on the drug and make that cost-sharing problem go away and have you kind of, quote, hooked for forever. I mean, and the administrative costs, you know, for all of that, the SG&A, forget about R&D, the SG&A type of that is gigantic.
All right, so we haven't solved drug costs. We haven't solved police brutality in EMTs. We haven't solved. We haven't solved much yet. So yeah, we didn't do the thing where we go around the start and think about what we've been looking at this week, which we normally do. I wonder if we should go do a slightly longer fade out here and go around and figure out what the big top. We did mention Don Berwick and Medicare Advantage, which, you know, have been a lot in the news this week. But I wonder if we should go around and think of a sort of slightly longer fade out here and of what you think the big topics, you know, that are coming up and people are going to have to look at in particular areas we study over the next couple of weeks. Jen, you briefly mentioned the GoodRx FTC thing, and we had talked, and I had Devin McGraw on here a few weeks back talking about the ONC criticism of basically the same thing, which is the sharing data from hospitals and others. And then there was a Stat News piece working on the Light Collective's working on Light Collective's original piece with Eric Paraxlis.
Eric Paraxlis.
Thank you for that pronunciation.
I know him well.
I don't know why he's involved with Eric. I just call him Eric.
He's a great guy. If you don't know or read Eric, You need to.
Yeah. Although I think he's left Twitter, like John Electric.
No, he did leave Twitter, but he's on LinkedIn, and
I was trying to tweet about him, and his name didn't come up. Anyway,
nope, he left.
But it might be worth touching base on that as to whether, because there was more stuff in Stat about digital health companies who were sharing their data, knowingly or unknowingly.
Yep.
And now we've had the fine for good RX of 1.5 million, which is
right.
the world's biggest fine, but it's something. So perhaps we should just quickly go around, touch on that, and then touch on any other topics we have as we get to the last few minutes here. So Jen, do you want to just say a word about that, as that you do live in that world?
Yeah, I mean, it's interesting, right? The question's been for too long, is FTC actually going to enforce this rule? And so, that question has now been answered. Yes, they are. And if you actually look at a lot of the quotes from leadership and from justice, it's aggressive language. This is not a one-off. This is not performative. This is actually a practice that they sort of intend to enforce. And I think here's what's interesting, right? And we can tie a few threads from today together, which is we were talking about this idea of providing solutions rather than recommendations. And we were talking about who's going to do that, right? The virtual care providers, in my opinion, are leading the way. We also talked about what's the facilitator for doing this. And we said that it's data. And I think what we have to realize is whether you're in a brick and mortar facility, whether you're in an insurance company, I don't care if you're in a PBM, right? Or if you're a virtual first care provider, your market differentiator is data driven these days and how you're using data. And I think that there's been in literally the last few days, a moment where you have to clean up your data practices, right? Ignorance is no longer an excuse. The legislation, the regulations are very clear indeed, and it doesn't matter who you are. You actually have to protect people's privacy. You have to avoid misuse of data, and then you have to behave accordingly, should a mistake happen. And I think that that's, to me, the biggest takeaway this week. And I think it applies to everyone. You can't just say, it's those companies over there. GoodRx has obviously been the company that's held up. But we all know that they are not the only company who's been behaving like this. We've got, data from excellent reporting, from excellent research. But, this data is now liquid and it's generated inside and outside of the clinic. And we have to change our practices. And I think the wiggle room to behave badly is, quickly being eaten away.
And I say hallelujah.
Couldn't agree more. Because if we lose trust in this, right, then all of the benefits that come from data-driven approaches, we're going to have to back away.
We're going to be suspect. Yeah, exactly.
100%. And so what we really have to make sure we do is make sure that our practices related to people's data are trustworthy, and not just performatively so. We actually have to behave in a trustworthy fashion.
I don't think it's the only reason that private equity has landed hard in the healthcare space over the last, let's say, 6 to 8 years. But I talked about my January episode of the podcast was me basically ranting about private equity as being a really, really bad player inside the healthcare sphere, because their mindset of primarily delivering shareholder value above all else kind of runs a Bradley fighting vehicle over the idea that people's data has value to them as a citizen, and those people should be involved in deciding what is done with it outside of clinical care, and the availability of the data to them and to their clinical teams. But I think that having private equity as a partner in whatever it is you're doing, whether it's a hospice network or putting together a physician network for, to staff emergency departments across America or whatever. There's, lots of places where these guys have shown up, and guys being generic. It's, men and women, everybody at once. But, it's like, it's all, everybody's in there. But I find that really disturbing and something that's not talked about enough. So I decided I was going to talk about only that for at least, 20 minutes, and, hoping that somebody is listening. And I know I'm not the only one saying this, but it's we got to get private equity with brains and their heart attached to understand that it's like, if you're stepping in here, you're stepping into a place where people live and die, and you need to honor that.
Well, I'd agree. I'd say that the piece that was written about, and I think, and I'm blanking with it, ProPublica or somewhere else about the nursing homes in New York.
It was ProPublica.
That's, and by the way, the people who were running nursing homes in New York, including a bunch of the people, and elsewhere, and a bunch of other places, where private equity comes in, weren't exactly shining angels in the first place, right? All these people.
No, they were not.
Were not, right? And there's been this stuff, it's been, you can get on the list of sort of, Russian mafia gangsters running Medicaid clinics, and it goes on, right?
Welcome to Brighton
as Kim
Beach.
said, there's nobody who's not like looking out for their partner. There are some very bad actors, and in some ways, the private equity folks are like driving this to the extreme, and we do need to get some kind of regulatory response to it. I would say, it's a very tricky thing. What the point Jen raised about the data, right? Obviously, the data matters a lot by and by. I'm now working with 3 different companies that I'm advising who are doing somewhere in the bones of putting data together and doing it to improve the patient experience, right? Trying to find people who are undiagnosed but sick, or trying to get people's data records together, trying to get them into clinical trials that they need to be into. Yeah, they're all doing it because they're good capitalists, but you can clearly see that if you could do a data-driven approach, you could get people to better care and hopefully cheaper care, right? Hopefully cheaper getting in there first and starting and not having.
Again, you can have data-driven solutions there.
Yeah, you've got to have them, but I mean, the ease with which that data can be, and Devon's been on talking about this obviously before. Devon McGraw from Citizens has been talking about this many times. That this can slip into stuff that becomes marketing or moving the data around in order to figure out how to get more money out of people instead of how to deliver better care. You got to wonder how that's playing out. All right, we have 2 minutes to go. We want to quickly go around and see what people are thinking of, what they're up to, where they're going, and what they're thinking about. They're going to be looking at the next couple of weeks. So I will start with you, Ian.
2 things. One is the public health emergency expiring. I know you guys talked about that in previous rounds. I am terrified we're going to leave a lot of people out because of Medicaid redeterminations returning. And the other thing is the future of the global economy is going to be dependent on Lauren Boebert and George Santos, for God's sake, which scares the hell out of me. But here's, I talked to some of the senior people at the AHA a couple of weeks ago about this, and Stacey Hughes, who's the new chief advocate there, said to me, remember what happened last time we had a debt ceiling battle and we got 2% sequestration on Medicare.
Right.
And, given the precarious finances of everybody I'm talking to on the health system side, we could get into some really squirrely numbers. So anyway, I'm watching that whole hospital financing thing very closely because nobody's making money right now, and it may turn around. Partly it's their own fault, but nobody's making money right now.
The good news was Margaret Taylor Greene, whatever her name is.
She's a moderate now, eh?
Well, the joke is she was on some committee explaining how one elementary school in Illinois got $5 billion for critical race theory. She kind of.
She can't even count. I just can't even with that woman.
But it's the Republican fallacy on spending is that all the money in the budget goes to national public radio and foreign aid, which is like the square root of zero in the budget, right? And the big buckets are Social Security, Medicare, and defense, right? And discretionary spending has gone down proportionally for the last 30 years.
And interest on that will be picking up. Kim.
Well, Ian mentioned the public health emergency. So related, I'm looking at the debt ceiling negotiations. The Republicans are now finally claiming that Medicare and Social Security are off the table. But when you look at what they do want to cut, they want to cut Medicaid, they want to cut Obamacare subsidies, they want to cut Section 8. So if you're a poor person,
they're coming for you.
Casey.
Oh no, I'm done. I did my rant about private equity. Let's toss it to Ian.
I don't know. It's Jen.
So a couple of fun things happening at Dime at the moment. So we've actually just released an applied digital health ethics course, direct to learner. Really proud of that. When we think about the sort of ethics around data use in particular, that's served really nicely by that program, and we hope a lot of people use it. We also
hang on. Is it called Dethics? Come on.
Oh, no.
Oh, but now I feel
No,
like we've
it's
missed
not.
a trick, Matthew.
You missed it. Sorry, I'm back to Silicon Valley and Dethics and digital health. All right. Sorry. Your second point. No, we've done Dethics. What's the second?
And I want to go back to this idea of virtual first care, and virtual first, not virtual only, really being in the language you like as providing solutions and not recommendations. And I go back to that virtual first care directory that we launched. And I think there's some really powerful examples. And for folks who don't follow along with, I think, the depth and maturity of this industry, I think there's a lot of value there, and I drive people towards it.
All right, wonderful. Okay, well, you have been listening to and watching, my good friends. Come on, little computer, you can do it. Here we go. Kim Bellard from the crazy Midwestern town of Cincinnati, who is, hang on, guys, didn't make the Super Bowl again. We're so close. I know you don't support them anyway. The Super Bowl will be a couple of weeks between a bunch of people who we don't support. Casey Quinlan from Richmond, Virginia, capital of the Confederacy. Jen Goldsack from the hellscape of Florida, which is now banning books and going to insist that young female athletes take their menstruation records into school with them. I cannot understand how the hell they're going to go that far. And Ian Morrison, who is doing well, having been running up the bill at Stanford with his heart. I am Matthew Holt. I want to say thanks very much to all of you for watching and listening, whether you're watching live, catching the video later, or catching us up on the podcast available on Apple and Spotify. This is THCB Gang. We'll be back next Thursday, Feb the 9th, with another edition of the Gang, where we'll talk about how in the last week, all of American healthcare has got solved. That's clearly can be the case. All right. Bye for now.